Good afternoon or good morning, everyone. How's everyone doing? My name is Corbinian Warner. I am a current second-year medical student at the University of Connecticut. And today I'm going to be talking to you about a project that I did a little while ago that looked at Munchausen's by proxy charges within the glycogen storage disease population and the lessons of how misdiagnosis of those charges can shed some light on future treatment for rare diseases. So just a little bit about me in case you have not heard my name before or I have not had the pleasure of meeting you at the most recent AGSD conference, which was back in 2019 in Houston. So I'm a previous employee of Connecticut Children's. I worked there within the clinical trials unit and the research department, specifically with Dr. Weinstein's glycogen storage disease program for just about 2 years. Prior to starting medical school. As I just mentioned, I am a second-year MD MPH, which is a Master's in Public Health student at the University of Connecticut, and am a member of the Association for Glycogen Storage Disease as well. So before I get started, I just want to give you all a brief understanding and background of what actual Munchausen's by proxy is and a history of kind of how the disease came to be what it is now known as. So if you just read the slide directly, you can see the definition that's characterized by the American Psychiatric Association, specifically their Diagnostic and Statistical Manual of Mental Disorders. So that last part, I want to just jump on that mental disorder. So Munchausen's by proxy is indeed considered a mental disorder, and it's something that is more or less manifested by an individual, usually a caregiver, will be making intentional symptoms or kind of physiological or psychological signs within the patients that they're taking care of for the purpose of seeking out medical care. So it's that want for medical care is what the caregiver is yearning and searching for. The actual origin of the name comes from a folktale. There was an individual who was named Baron von Munchausen, and he was known for coming up with these massive fictitious stories and kind of weaseling his way through life in that sense. About 25 years later, it was at first used in the medical context where you had these not to true origin clinical signs and symptoms of being seen by medical providers in patients, and they couldn't really attribute what actually is causing those signs and symptoms. So hence the name Munchausen's by proxy. And it is a charge that can be filed by a physician or a medical care provider, typically involves some kind of interdisciplinary team as well. So I wanted to just talk about Munchausen's in the context of rare diseases. So these charges are typically administered due to a presentation of a patient where the medical conditions are unknown. And they're either weird or they're not necessarily something that medical provider sees often. And that's the key part where rare diseases come in. As we all know, glycogen storage disease is indeed quite a rare disease, and many medical providers, I can speak from personal experience, will learn about glycogen storage disease the first few weeks of medical school, and for the most part, never see it again. And as a result, that disease typically shows quite a lot of unique clinical characteristics, as I'm sure you're all aware of, things like fasting hypoglycemia, metabolic acidosis, a large liver, and many more symptoms depending on the type of GSD. And as a result, this can cause the medical providers to be a little uncertain and unwary of precisely what the underlying etiology, we would call it, or the underlying reasons for that disease. So within Munchausen's by proxy confirmed diagnoses, we typically see mainly children being the victim. So we usually see most often a maternal caregiver. And there's a study that I reference on the slide as well, where over 97% of cases, and this is a case study done a few years ago, looking at 800 occurrences of Munchausen's by proxy, where over 97% of those were committed by a female caregiver. We do also see it in adult victims. Oftentimes, these individuals have some sort of disability, whether that's a mental handicap or a physical disability, and they're not necessarily able to take care of themselves as well. So again, it is primarily a children's afflicted disease or psychological condition from the caregiver, and it does make up about 4% of all child abuse cases as well. So if you look at the kind of pictogram diagram at the end of the slide there, we see that a combination of the unfamiliar clinical presentations of rare diseases plus the unfamiliarity of the actual disease by that provider is going to result in these false charges potentially being as part of their differential. Because again, they're thinking, okay, I can't attribute what is actually causing these symptoms. I don't know what's going on. Maybe it's something that's being done by the caregiver or by the actual parent. And that might actually explain what's going on specifically. So just going into the project design and how we went about doing this as a center. So we had 3 families that we isolated based on the collection of patients that were being seen by the Connecticut Children's Glycogen Storage Disease Program. And they were all enrolled as part of a natural history protocol. So this protocol allowed us to extrapolate certain aspects of the medical chart that revealed an aspect of upbringing with glycogen storage disease, natural developmental aspects seen, labs, things like that. However, we wanted to look a little bit more specifically into the actual experience of what those families went through. So we, in addition to finding these 3 family members, which you can see on the slide, had 1 male patient with confirmed GSD1A in the first family. The second family actually had 3 children, all atypical untyped glycogen storage disease. However, they had a pretty common genetic conformation in certain mitochondrial complexes within the electron transport chain, and they all had clinical glycogen storage disease signs. And family 3, where we had an individual who had 2 copies of 2 different types of glycogen storage disease. So as we all know, you do need 2 copies of that mutation to have a full-blown disease. So he had 1 copy of type 0 and 1 copy of type 6. And we did a case study analysis based on over-the-phone interviews that were conducted over the course of a few hours. Sometimes it did require a little bit of a follow-up as well to make sure that we had all the facts straight in the story, and we took notes on that and then compared the experiences and commonalities seen within each of those family members. So at first, I just want to go through each of the cases, giving you all a brief summary, and then we'll go into the commonalities seen. So for case 1, this was the individual with confirmed glycogen storage disease type 1A, and we saw several clinical signs that I'm sure we've all seen before. So we saw lethargy or tiredness, difficulty breathing, severe hypoglycemia. We saw a large liver, what we call hepatomegaly. We saw lactic acidosis, hyperlipidemia, which it just essentially means higher amount of fat within the blood. We saw hyperuricemia, and this was all happening from birth to about 2 months old in this child. Right at that 2-month-old mark is when that genetic confirmation came back as glycogen storage disease type 1A. The cornstarch regimen, which started at about 11 months age, and you'll see that it was started at 2 grams per kilogram of body weight and was very poorly managed to the point where it actually was bumped all the way up to 4.6 grams per kilogram of body weight, which is a crazy increase of, close to 200% more of what was already given to this child, and the symptoms were not improving, and the cornstarch dosing was just increased further and further by metabolic specialists. So as a result, the family felt as though they were kind of out of luck and out of options, and through a panel, they were able to encounter a GSD expert who was now able to intervene, and now that there was a confirmed glycogen storage disease type 1A diagnosis, and provide some assistance. Prior to that assistance, however, happening, the medical services team, which was an interdisciplinary team of dietitians, medical providers, nurses, did contact Child Protective Services. And this is the equivalent of essentially the first step of creating this diagnosis of potentially thinking Munchausen's by proxy is at play. So the providers were thinking, this child is not getting any better. We're doing what is under our training and our understanding the most appropriate methodology of actually being able to treat this patient, but the child isn't getting any better. So as a result, the metabolic specialist did file those Munchausen's by proxy charges, and the family only hope was truthfully to be able to go see that glycogen storage disease specialist. And they got that piece of advice from one member of the dietitian's team, and they were able to then go see that specialist at their center and be able to receive the treatment that they needed. However, that did require truthfully moving heaven and earth, including taking out a loan to fund their trip down there and to fund the visit, getting passports as they were an international patient, and many more things to make sure that they were ready for this appointment. So the family was put under an incredible amount of stress just due to these false accusations that they were actually causing their child to get even worse clinical symptoms. The second example is slightly similar. However, here we see 3 children with an untyped diagnosis of glycogen storage disease. So they all had some of the symptoms that you typically would see with GSD. So we saw neonatal hypoglycemia. They had various signs of failure to thrive, and they were missing milestones. They had some recurrent metabolic acidosis and infections, and they had some fasting hypoglycemia and neutropenia. So these were all kind of manifesting themselves as several different subtypes of glycogen storage diseases, however, all clinically classical symptoms of these diseases. As a result, the children were all sequenced genetically and were found to have deficiencies in complexes 1, 2, and 3 within the mitochondria. However, there were not any found specific glycogen storage disease genetic difficulties, and the children were therefore just continued to be seen by several metabolic specialists, providers that were specialized in mitochondrial disorders. They were put on uncooked cornstarch as well. And they had several standard of care surgeries, or what we would consider normal operations for children to have. For example, a tonsil removal. If a child had a recurrent infection, that's pretty common surgery to occur. And with the issues and failure to thrive, making sure that child receives enough nutrition, therefore a G-tube was installed. However, what caused the red flags from the Child Protective Services team was that all of these procedures and appointments and everything were being done in a very condensed time frame. And due to the nature of there being 3 children involved, the chart review that they then conducted realized and revealed that there were quite a lot of specialists and medical providers seen for what would be considered a quote unquote normal child in comparison. As a result, just due to a chart review and no interviewing of the parents or any kind of consultation from an interdisciplinary team, Child Protective Services got involved. They made unannounced visits to the home and called personally on the parents' cell phones as well, in terms of trying to figure out what was going on and what the situation entailed. The charges were ultimately dropped due to a social worker getting involved and realizing that these 3 children had round-the-clock nursing care, that they had confirmed mitochondrial disorders that mandated those, and they had several untyped GSD symptoms. So that would not have happened if that social worker had not gotten involved. And again, we see a situation where a medical provider care team is making an assumption that everything that they're necessarily doing and within their scope of understanding is not necessarily making these children do any better. Our third example is an orphan child. So there's actually not too much known about their neonatal history. However, we do know that they did have a history of recurrent seizures and infections. So again, we're thinking what's causing those symptoms to occur. Upon entry into the United States and full and complete adoption, the child was indeed diagnosed with ketotic hypoglycemia, and a fasting hypoglycemia study was done. And after about 14 hours of fasting, the blood sugar was in the low 40s. So that confirmed the hypoglycemia diagnosis, and uncooked cornstarch dosing was indeed recommended, but not necessarily done. And it was actually self-dosed by a mother who was an ICU nurse, and she went out and found the resources, found publications that showed a child or several children that had a pretty similar clinical profile as the child that she had, and she started using uncooked cornstarch and self-dosing that as well. Shortly thereafter, some genetic mutation or genetic analyses were done, and 2 heterozygous mutations, which we would call synergistic heterozygosity, showed that this child did have 1 mutation in type 0 and 1 mutation in type 6. So now that we had an idea of some kind of glycogen storage potentially being involved, the mother had a little bit of a better understanding of what her child potentially was suffering under. However, the child was still not doing well, and upon one visit to the emergency department due to recurrent vomiting and hypoglycemia, the mother did administer some of her own oral glucose while the child was in the emergency room, noticing that he was experiencing symptoms of hypoglycemia. A GI specialist was asked to be of assistance to the attending within the emergency department, and them witnessing this oral administration of glucose while the child was hypoglycemic resulted in the GI specialist filing Munchausen's by proxy charges, thinking that that was potentially the reason for why this child is not doing any better, due to the fact that they don't have a confirmed homozygous mutation in any type of genetic disorder or metabolic disorder, and resulting in the symptoms of metabolic acidosis and fasting hypoglycemia that were seen in this patient. As a result, another specialist was brought in for a second opinion, and that was actually what caused the charges, thankfully, to be dropped due to him citing the GSD commonalities. So as a result of those 3 cases, I want to just point your attention to several overlapping features that we see in all 3 of those examples. We see parents accused of overtreatment and overzealous care due to getting surgeries that are not necessarily given context of why those are happening, or uncooked cornstarch being administered even though that's the most recommended approach. We see excessive procedures and surgeries and specialist appointments seen, one child being seen by half a dozen providers without any given context, and just looking at it from a 10,000-foot perspective does not necessarily shed true light on the reasoning and the rationale for why this child is seen by so many specialists. We see a lack of a GSD expert. This is one of the clinical most prominent features, in my opinion, is that you did not see any contact to a GSD expert prior to a Munchausen's by proxy filing, and only in 2 out of the 3 cases was a GSD expert contacted after confirming the GSD genetic analysis, and that was already after the Munchausen's by proxy files had been charged. You saw a lack of parent observation and interrogation, and this is a critical component of Munchausen's by proxy charge filings seen in previous literature, is that you need first and foremost an interdisciplinary team, and second of all, some kind of interview or interrogation or observation of the parents to see if there's actual proof behind these assumptions of Munchausen's by proxy. You saw a lack of parental psychological evaluations. Interestingly enough, the 3rd case, the father of that child actually is a specialist in mental health and treats patients with mental health disorders, and interestingly enough was not questioned or himself given a mental health screening, nor was the mother. And that's another critical component going back to the beginning of my presentation, and the fact that Munchausen's by proxy is in fact a mental disorder. So it would only make sense for that to be a critical component of the actual diagnosis and filing of charges for Munchausen's by proxy. And as a result, the biggest overlapping feature is now all 3 of these family members have a lack of trust with medical providers. And that in itself, with having a rare disease and being uncertain and feeling certain elements of uncertainty with that disorder and feeling alone and unsure of where to turn, now you have the individuals that you put your child's life in their hands, accusing you falsely of manipulating the child's health in order to seek this medical care, this unneeded medical care, which is just unfortunately not correct. So in terms of future approaches from this analysis and this case review, is we see that rare diseases have truly complex medical profiles, and the uncertainty of treatment results in false Munchausen's by proxy charges being proposed pre or post diagnosis of the rare disease. And that's truly pretty concerning and sheds light on a systemic issue in terms of using these assumptions prior to any kind of diagnosis, before even thinking of a wide-ranging differential, when you're thinking about what's actually the disease that's causing the child specifically to have these symptoms. And lastly, you're seeing parents seeking specialist care is now being seen as parents overzealously treating their children. You see a parent that gets frustrated and seeks out certain metabolic specialist or a dietitian, or certain procedures are then recommended because of that. And this is seen as overzealous and unneeded care, which is just contributing to a false Munchausen by proxy filing. So fundamentally, I think a future approach is we as a medical institution and medical administration and society need to look at how we go about charging individuals and caregivers with Munchausen's by proxy, especially in circumstances where there's no interdisciplinary teams involved and no mental health evaluations. So those are two critical elements of the filing infrastructure that need to be included in the actual charging of Munchausen's by proxy in order to prevent any undue stress and harm caused by these family members. And most of these occurrences happened with the children being less than 5 or 6 years of age, and most of those children are now well within their teenage years, and these family members still have quite a jarring and scarred memory about this, and are quite emotional about it. So it just shows the longevity of potentially accusing someone falsely under this Munchausen's by proxy diagnosis, which is truly unfortunate. So to wrap things up, I do just want to acknowledge the Glycogen Storage Disease Program team. It was a fantastic group of individuals to be able to work with and still work with to this day, which is really just a true definition of individuals that are passionate for this disease and are doing their utmost best to try and improve care and push research and push the improvement of general quality of life for these patients. I'd also like to thank Connecticut Children's and the University of Connecticut for providing the actual locations to be able to conduct these research studies, not just ones that I'm doing, but other ones as part of our team, and to provide us the ability to see patients with this disease. And I would just like to lastly, also thank my collaborators, Iris Ferrecchia, Dr. Patrick Ryan, and Dr. David Weinstein. All three of those individuals helped me in the actual conductance of the interviews, compiling and summarizing the case studies, and ensuring that all stones were unturned, and I'm very appreciative of their help. And lastly, but not least, here's my contact information. This is my current email address in case you have any further questions or have any other questions that I might be able to address or point your attention towards. And let me know if you have any questions regarding this project.